Hi, this is Dr. Gardner, and I will be lecturing on feeding, eating, and elimination disorders. These are the objectives, and I will allow you some time to read the objectives. So, feeding and eating disorders are characterized by a persistent disturbance of eating or eating related behavior that results in altered consumption or absorption of food that significantly impairs physical health or psychosocial functioning. Obesity is not classified as a mental health disorder, but it is associated with a number of mental health disorders such as binge eating disorder, depressive and bipolar disorder, and schizophrenia. So this lecture will cover the feeding and elimination disorders that include anorexia nervosa, bulimia nervosa, avoidant and restrictive food intake disorder, binge eating disorder, rumination disorder, pica, enuresis, and encopresis. So we'll start off by talking about anorexia. And the DSM-5-TR says that anorexia is a restriction of energy intake relative to requirements leading to a significantly low body weight in the context of age, sex, developmental trajectory, and physical health. Significantly low weight is defined as weight that is less than minimally normal for children and adolescents, less than minimally expected, and we'll go over some of those weights. Intense fear of gaining weight or becoming fat, or persistent behavior that interferes with weight gain, even though at a significantly low weight. So it's also the disturbance in the way in which one's body weight or shape is experienced. Undue influence of body weight or shape on self-evaluation or persistent lack of recognition of the seriousness of the current low body weight. And there's different ICD-10 codes for anorexia, and they're dependent on subtypes. So what are those subtypes? Well, F50.01 is the restricting type. And that's during the last 3 months, the individual has not engaged in recurrent episodes of binge eating or purging behavior, like self-induced vomiting, laxatives, or diuretics, or enemas. F50.02 is the binge eating purging type. And that's where during the last 3 months, the individual has engaged in recurrent episodes of binge eating or purging behavior, self-induced vomiting, misuse of laxatives, diuretics, or enemas. So you'll also note when you're making a diagnosis of anorexia nervosa, are they in partial remission, or are they in full remission? Partial remission is after the full criteria for anorexia nervosa were presently met. Then criteria A, the low body weight, has not been met for a substantial period of time, but either criteria B, intense fear of gaining weight or becoming fat or behavior that interferes with the weight gain, or criteria C is still met. So maybe they're coming up to a normal body weight, but they still have that fear of gaining weight. So they've been in treatment, they're getting their weight back to normal, but they're still afraid of being fat. That is not full remission. That's partial remission. They're in full remission if after the full criteria for anorexia nervosa has been met for a sustained period of time. So they're at a good body weight. They don't have that fear of becoming fat, or they're not expressing that fear. They're not afraid. They're okay being their weight, and they don't have a distorted perception of their weight, their understand their weight. So there's different severities. So mild if they have a BMI greater than or equal to 17. So I know you don't see the greater than or equal to sign, so I am expressing that to you. It is mild if their BMI is greater than or equal to 17. It's moderate if their BMI is between 16 and 16.99. That's moderate. They have severe if their BMI is between 15 and 15.99. It is extreme if their BMI is less than 15. So you could go either way when we're talking about these. We could start at extreme and say, if their BMI is less than 15, oh my, they're in trouble. If their BMI is between 15 and 15.99, it is severe. If it's between 16 and 16.99, it's moderate, and it's mild if their BMI is greater than or equal to 17. So about 0 to 0.5% is where the prevalence is with anorexia, so it's not as prevalent as we would imagine. It does affect women greater than men, and the lifetime prevalence of anorexia is about 0.6 to 0.8%. So risk factors for developing anorexia is anxiety, OCD. It could be occupational, where they have elite athletes or modeling who have to be thin, or thrive on being thin, or perform better on being thin, like marathon runners. It is also genetic, so there's a high tendency of maybe a mother having an anorexia and then her daughter having anorexia too. And also the reverse, if a mother is morbidly obese, she may have a daughter who's anorexic because that daughter has got that fear of being fat. Um, Cultural, as far as it's not as prominent in among non-Hispanic blacks or Hispanic populations. Some of the risk factors for developing anorexia also include trauma, society. And why is it society? Because of look at all the commercials and look at all the ads. They advertise people who are thin. I mean, now we have a few more commercials where people are not, but the majority of advertisements, society, even occupational, it's on being thin. So that is also a cause. Dieting behaviors, especially if they begin early on, or that need to be perfect. Those people who have that I need to be perfect mentality. They need to be perfect at work. They need to be perfect at school. They need to be perfect in their family. And they're not perfect unless they have a certain body weight. So what are some of the diagnostic markers? Well, we need to do a CBC. That patient may present with leukopenia, mild anemia, or thrombocytopenia. We do chemistries, they could be dehydrated, and you'll see an elevated BUN. They may have elevated hepatic enzymes. They may have hypomagnesemia. They may have hypozincemia. They may have hypophosphatemia or hyperamylasemia, increased amylase. And their EKG may show some sinus bradycardia or even some significant prolonged QT intervals. So self-induced vomiting may lead to a metabolic alkalosis, like they may have an elevated serum bicarb, and laxative abuse may lead to metabolic acidosis. Their serum T4 is usually in the low to normal range. Their T3 is decreased and the reverse T3 is elevated. Am I going to ask you to memorize their thyroid studies? No. Do you need to know that it's important to check their thyroid studies? Yes. Females may also exhibit low serum estrogen levels, and males may have low serum testosterone levels. Their fasting glucose may also be low when they're in that emaciated phase. So again, while I do not expect you to memorize lab values like with the thyroid, I do expect you to know if you are treating one of these patients, what kind of labs would you get and what would you be looking for? Because you have to understand that. So we go back to assessment as a part of it, but also your responsibility as a provider. If you're seeing somebody who is presenting with a low BMI, possibly restricting their foods, what are you going to look for? You're not going to just treat them with therapy and medications. You are responsible for checking labs on these patients. And because you're checking labs, you need to be aware of what you're looking for. So I'll leave this screen up so you guys can take some good notes on that and have an understanding of what you're going to be checking your patients for. So your physical exam, what you may see on exam or what your patient may express, females may have amenorrhea, or if they haven't started their cycle yet, they may have delayed menarche. So that is something you want to assess for. You ask when was your last period. When you're treating females of childbearing age, you always want to ask when was your last menstrual cycle. They may complain of constipation, of abdominal pain. They may have a cold intolerance, be very lethargic. Some of them may present with excess energy, or, we always want to say that they're going to look emaciated, but they may not be at that point where they're looking emaciated. So you need to know what you're looking for. They may have significant hypotension, hypothermia, or bradycardia. Some individuals develop lanugo, and that's that fine, downy baby hair. They may even have peripheral edema, which is noted when they're in that weight restoration period. So don't be alarmed if they come in and they've got some swelling when they're starting to gain weight. Self-induced vomiting may lead to hypertrophy of the salivary glands, particularly the parotid glands. And what you need to know about these patients, when are you going to admit your patient? That decision is based on the patient's medical condition and the amount of structure needed to ensure cooperation. So each case is individualized, but I will give you guys a good list of some criteria that is going to meet hospitalization. But in general, patients who are 20% below their expected weight for their height, they're recommended for some type of inpatient treatment. So you need to know if they're 20% below their expected weight for height, they're going to be recommended for inpatient treatment. Now, they may be able to go to inpatient treatment. They may not need medical intervention. So you'll have to know the difference. Who needs psychiatric care inpatient or who needs to actually go in the hospital for medical treatment. So you're going to have to put on those assessment skills. Patients who are 30% below require hospitalization for anywhere from 2 to 6 months. So they're 30% below. Depending on their presentation, you know this person is going in the hospital. It is whether they're going medical and then psych or if they're going psych. But if they're going in the hospital for treatment, there are definitely a lot of programs out there that help, but they're not going in for a brief period of time. This person's 30% below their recommended body weight for their height, and they're going to be in the hospital for a while. Some of the differential diagnoses for anorexia, it may be somebody that has a GI disease, occult malignancy, AIDS, major depressive disorder, substance use disorder, social anxiety disorder, body dysmorphic disorder, OCD. They may have bulimia or avoid and restrictive food intake. So you need to know that some of these are differentials. Again, using your assessment skills, you'll know which your patient falls into. Some of the comorbidities include bipolar disorder, anxiety, OCD, alcohol use disorder, substance use disorder, and trauma-related disorders. So when you're doing your assessment, remember you're going to include medical, psychiatric, nutritional, physical. Make sure you get a height, weight, and blood pressure on your patient, and labs. You're going to get electrolytes, calcium, magnesium, fasting glucose, albumin, prealbumin, amylase, lipids, CBC with platelets, and an EKG. Excuse that D, that's supposed to be a G, an EKG. So the treatment, psychotherapy is the treatment of choice, and use of refeeding protocols. So those two are top the list. Family-based therapy is preferred, and of course, when you're treating somebody with anorexia nervosa, a collaborative-based care is essential. Now, some of the medications that you may use would be like cyproheptadine, which is periactin, and it has an antihistamine property, but it also stimulates the appetite. So patients taking periactin usually can gain some weight. Amitriptylines used, Prozac, um, Primidone, Anafranil, and Thorazine. I may have that spelled wrong, or rap. It may be spelled wrong. But so the oral medications you may not use unless they have comorbidities. Definitely the treatment of choice is going to be psychotherapy and use of refeeding protocols. Now, if they have comorbidities, definitely you're going to use medications. SSRIs have been used quite frequently. Periactin may be tried to get them to eat. So hospitalization, and this is not for inpatient care. This is more, well, it's inpatient care for medical and inpatient for psych. So you'll need to know where your patient needs to go. If they have profound hypotension and an arrhythmia or a severe bradycardia, where are you going to send them first? If they have severe electrolyte abnormalities, dehydration, again, profound hypotension, where will you send them first? Yes, they do need psychiatric treatment, especially if they have a suicide risk, but you have to know, do they require medical treatment before psychiatric treatment? And what would be the deciding factor on where you're going to send them? A BMI of 15 or less requires hospitalization. So they may be able to go to inpatient treatment, but you need to know that if their BMI is less than 15 when you're seeing them for their weight, that's an admission. So we'll move over to bulimia nervosa. The DSM-5 TR says that recurrent episodes of binge eating. An episode of binge eating is characterized by both of the following: eating in a discrete period of time, so like within a 2 hour period, an amount of food that's definitely larger than what most individuals would eat in a similar period of time under similar circumstances. So somebody who's with bulimia that's binge eating may eat a whole pizza, a bag of chips, not just a personal size bag, but like a family size bag of chips, add in a couple cupcakes, a 2 liter of pop, and some cookies, all within a 2 hour period. And they feel sick. But that's definitely larger than what somebody else would eat in that same amount of time. They also have a sense of lack of control during that period. So they want to stop eating. They know what they're doing. They're binge eating and they don't want to, but they can't control it. Even if they're feeling like they're full, they're still eating in that 2 hour period of time. Recurrent, inappropriate compensatory behaviors in order to prevent weight gain. So they've eaten all this food, way more than a normal person eats in a 2 hour period, but now they've got to have some behavior so they don't gain weight from that. So they may self-induce vomiting, use laxative, diuretics, or some other kind of medication, or they may fast. They may have a period where they eat all that food for 2 hours and then they fast for a couple of days so they don't gain weight from that period. Or they eat all that food within a 2 hour period of time and they go and exercise for 5 hours straight. The binge eating and inappropriate compensatory behaviors both occur on average at least once a week for 3 months. So they're going to binge eat at least once a week for 3 months. Self-evaluation is unduly influenced by body shape and weight, and the disturbance is not happen during any episode of anorexia nervosa. So there's also partial remission or full remission for bulimia nervosa, and I'll let you read those. So they may have, there's different categories. There's mild, which they have an average of 1 to 3 episodes of that inappropriate compensatory behaviors per week. So they binge and then they may purge. Moderate, they're having 4 to 7 episodes of that inappropriate compensatory behavior per week. So they're binging 4 to 7 times and then they're purging 4 to 7 times. It could be severe, where that's 8 to 13, or extreme, when it's 14 or more episodes of that inappropriate compensatory behavior. So what's the prevalence of bulimia nervosa? It's about 0.14 to 3%, definitely more common in women than men. Common in adolescents, 13 to 18 at about 1.3%. Girls more than boys. And this is similar across all ethnic groups. So it does not discriminate. Some of the risk factors would it be weight concerns, childhood sexual abuse, physical abuse, childhood obesity, social anxiety, low self-esteem, depressive symptoms, childhood generalized anxiety disorder, and of course, there is a propensity that it runs in families. So some of the lab abnormalities, you may see some hypokalemia, hypochloremia, or hyponatremia. They may also have some arrhythmias from the hypokalemia. The physical exam might be unremarkable. However, some may show significant and permanent loss of dental enamel due to all of the vomiting that they're doing. Their teeth may have a chipped appearance or appear ragged and like moth-eaten, or they may have a lot more dental caries than the regular person. Serious cardiac and skeletal myopathies have been reported among these individuals, who reportedly use that syrup of Epicat to induce vomiting. So if you have a patient that you're treating, you definitely want to warn them to stay away from the syrup of Epicat. because of the skeletal myopathies and the cardiac complications, the arrhythmias that can arise from it. Some complications, females may experience menstrual irregularity. They may have nutritional deficiencies or emotional stress, esophageal tears from all the vomiting, of course, fluid and electrolyte disturbances, gastric rupture, cardiac arrhythmias, and these patients are an increased suicide risk. So some of the differentials would be anorexia, binge eating or purging type, binge eating disorder, MDD with atypical features, by borderline personality disorder, or the Klein-Levin syndrome. So in certain neurological or other medical conditions, such as that Klein-Levin syndrome, there's a disturbed eating behavior, but the characteristic psychological features of bulimia nervosa, like that over concern with body shape and weight, are not present in a patient who has Klein-Levin syndrome. Some of the comorbidities, mental disorders in general, any of them, you can pick one. Major depressive disorder, bipolar disorder, mood disorders, so many of them are comorbid with bulimia nervosa. So we'll move on to avoidant restrictive food disorder. And that is an eating or feeding disturbance with an apparent lack of interest in eating food or avoidance based on sensory characteristics of food. So it has a lot to do with maybe the smell of the food. There's a concern about aversive consequences of eating associated with one or more of the following. Significant weight loss, like failure to achieve their expected weight gain or faltering growth in children. Significant nutritional deficiency, marked interference with psychosocial functioning, and dependence on tube feedings or oral nutrition supplements. The disturbance is not better explained by lack of available food or by an associated culturally sanctioned practice, because that is a thing. The eating disturbance does not occur exclusively during the course of anorexia or bulimia, and there's no evidence of a disturbance in the way in which one's body weight or shape is experienced. In some patients, avoidance or restriction is based on the sensory characteristics, again, such as the appearance of food, the color, the smell, the texture, the temperature, or the taste. So some of the diagnostic features, you may see significant weight loss or significant nutritional deficiency in these type patients. They may have food refusal where they're gagging or vomiting because they don't want to eat and they're being forced to eat. Mama's trying to make them eat this food and they can't stomach it. They're gagging or vomiting because they're being forced. So some of the risk factors of this includes anxiety, autism spectrum disorder, OCD. Mother with an eating disorder may have an infant or a young child who's got this avoidant or restrictive food disorder. They may have gastroesophageal reflux disease, and so they don't want to eat because they're getting sick when they do eat. So we'll move on to picas. Pica is a persistent eating of a non-native, non-food substance over a period of at least a month. And what do I mean by a non-native, non-food substance? Food selections may include stuff like clay, plaster, paint, hair, cloth, insect droppings, pebbles, sand, or dirt. The minimum age to diagnose a child with pica is 2 years old. So the eating behavior occurs, it's in a non-food substance which is inappropriate to the developmental level of that individual. And C is the eating behavior does not occur in the context of another medical condition. So there's two different ICD-10 codes. There's pica in children and there's pica in adults, and you have to make sure when you're treating children you're using the correct code. So about 5% of school-age children have a pica. And some of the risk factors, lack of supervision, developmental delays, or neglect. And although deficiencies in vitamins and minerals have been reported, like zinc and iron, there's really no biological abnormalities that are found in most of the cases. So it's not always that someone has a pica because they're iron deficient. Some people just have picas. So some of the complications that a child may develop from having pica, infections, poisoning, intestinal perforations, mechanical bowel problems, or intestinal obstruction. Some of the diagnostic markers is this child may need a abdominal flat plate x-ray. They may need an ultrasound or some blood and lab tests to see if there are any deficiencies. So we'll move on to rumination disorder, and that is a repeated regurgitation of food over a period of a month. Regurgitation of food may be rechewed, reswallowed, or spit out. Some of the associated factors would be position of straining and arching of the back with the head held back. They may make sucking movements with their tongue. They may be malnourished, or they could be hungry or irritable in between feedings. Some risk factors include psychosocial problems such as lack of stimulation, neglect, stressful life situations, and problems with the parent-child relationship. About 1 to 2% of grade school children are diagnosed with rumination disorder. Onset can occur in infancy, childhood, adolescence, or adulthood. The age of onset is usually between 3 to 12 months, and there's a high incidence that's seen in those individuals with developmental disorders. So again, this can occur in infancy, childhood, adolescence, or adulthood, but the age of onset is usually between 3 and 12 months. And it's seen often in children with developmental disorders. So we'll move on to enuresis. And what is that? That is a repeated voiding of urine into the bed or clothes, and it can be involuntary or intentional. The behavior is clinically significant, is manifested by either a frequency of at least twice a week for at least 3 consecutive months, or the presence of clinically significant distress or impairment in social and academic or occupational or other areas of functioning. And they must have a chronological age of at least 5 years old before you diagnose them with enuresis. There's 3 types: nocturnal only, diurnal only, or nocturnal and diurnal. So one, nocturnal is the passage of urine only during nighttime sleep, whereas diurnal is during waking hours, or they could have a combination of both. I'm not sure if this is still on the market, but DDAVP was used to treat children with enuresis. I think it is on the market. However, it may be hard to get approved by insurance companies unless the child has been worked up by a nephrologist. Children, if they're taking DDAVP, should not consume more than 8 ounces of liquid at night, um, before they go to bed on nights that you are giving them the DDAVP. And if they are on DDAVP, you need to monitor their serum sodium for hyponatremia. As a psych NP, you'll have to determine when to treat these children. How you want to know how frequently is the child wetting the bed? Is it affecting their self-esteem? Um, and is it possible they may soon experience a spontaneous remission? So you want to also know, is this child being held from going to sleepovers, like they can't go to summer camp because they're terrified they're going to wet the bed and all the kids are going to tease them? If you choose not to treat them with medication, there's also the bell and pad conditioning that could be considered, and that's like an alarm system. I think that's what most insurance are wanting you to use first is that bell and pad. So if it's an alarm to where if they wet the pad, the bell is going to go off when they start to wet and hopefully stop them so they don't wet the bed. So that is an option before medications, especially when insurance companies want a complete workup, maybe by a specialist before they're started on DDAVP. So about 3.2 to 9% of children in the United States age 7 have enuresis. About 1.1 to 4.2% in the youth ages 11 to 13. And it's still about 1.2 to 3% in adolescents ages 15 and 17. So that's a lot of kids that's effective in the United States. It is more common in males than females. Some of the risk factors include delayed toileting and psychosocial stress. So maybe the child is getting potty trained and they're having accidents and mom or dad is yelling at them because they're having accidents. That is not going to help that child get potty trained. Or it could be genetic, where it does run in families. Some of the functional consequences, the amount of impairment is associated with the limitation on the child's social lives. Again, is that child being held from sleepovers or summer camp because of this? Or the effects on the child's self-esteem. Um, it could depend on the degree of social ostracism by their peers, the anger and punishment or rejection on the part of the caregivers. Parents get upset when they have to wash those sheets. So all of this adds added stress to those children. So if there's a child that's already bedwetting and the parents are really angry, punishing the child because they're wetting the bed, it is a vicious cycle and that's not helping that child in the least. So encopresis is the repeated passage of feces into inappropriate places, like the child's pooping on the floor or in their clothing, and this could be involuntary or intentional. At least one such event occurs each month for at least 3 months. Chronological age is at least 4 years old or their developmental equivalent, and the behavior is not attributable to another physiological effect or a substance. So there's also with encopresis, it is with constipation or overflow incontinence or without constipation or overflow incontinence. About 1 to 4% prevalent in high income countries. It's more prevalent in children that are 4 to 6 years old, higher in children who experience abuse or neglect, and low income youth. So some risk factors for a child having encopresis would be painful defecation, anxiety or depression, some behavioral disorders. Maybe they're going through some kind of psychological stress, like being bullied at school or not doing well at school. The male gender is also a risk factor for encopresis. Okay, so that covers all of the feeding, eating, and elimination disorders. for this module. Please let me know if you have any questions by sending a message through Canvas email, and I will post the answer as an announcement. Thank you.